So we have plenty of time. Get involved in the discussion, get involved in the questions, because prevention is one of those really interesting areas. And it's a bit like what was discussed earlier around the term goal. Prevention is one of those terms that we very often have very different ideas about. So it's really important that we take different perspectives. And we're going to have a really interesting session just now on different ways of looking at prevention. So I'm very, very pleased to introduce Dr. Johannes Schuch. And he has very kindly at the last minute stepped in for Dr. Sabrina Neururer. Now, I'm not going to go into detailed introductions on the speakers because you have access to their biographies and also the abstract. So I invite you, if you want more information, to do so. But I'm sure Johannes will share with us the wonderful work that they have been doing. And the title of this presentation is A Pathway to Prevention, the Concept of the Tyrolean approach, and I apologize. I haven't had my coffee, so my tongue is getting stuck to the roof of my mouth. Apologies. Over to you, Johannes.
Hello, thank you very much. It's always difficult to speak Tyrolean. Okay, my name is Johannes Schuch, and I'm filling in for Sabrina, so you won't find my CV in the internet. So just a short introduction. By training, I'm a GP, and I've been working for the Tyrolean government for more than 30 years. I'm now retired, and I was working as a district health officer in an area, and I did a lot of preventive work there. And then I moved on to the Tyrolean government central station, and there I worked in hospital planning, then education of doctors, and a lot of integrated care planning, which was starting then. Okay, and I'm going to follow through this Tyrolean prevention pathway together with you. I filled in on very short notice, but I tried to give my best. So let's start. This is something that's familiar for everybody, at least in the Western world and in the European countries. We have this age distribution, people getting older and getting increased need of care, and the burden for the healthcare system is always growing. So next Austrian position would be, we spend about 12.2% of our GDP for healthcare, but we are not as good as in healthy life years. We are just about EU average. So means we have a gap there. Now, that's the big question. Isn't prevention better than cure? And so we built this Tyrolean pathway for prevention. I want to go through this pathway together with you. And just in the very beginning, what is the process like? First, we always have an annual checkup as the GP, highlight the health potentials, mutually define the goals, contact the coordination for prevention, receive information, participate in prevention, and follow-ups. We are now going into the details. Okay, health checkups have been in Austria for a long time, and there is the possibility to have an annual checkup at the GP. And it is paid by the Social Security, and it is used quite frequently, but not extremely frequently. Second step is that together with the GP, the patient has to highlight the health potentials. Okay, they can be in different fields like hypertension, and then also obesity, addictive behavior, physical inactivity, sexual health problems, mental health problems, so on and so forth. Together with the GP, they try to find goals together. That's, I can refer to the session before. It is very important to have patient-centered goals, so this is a step in this direction. Now this coordination office comes in. This is at this Federal Institute of Integrated Care in the Tirol, and I'm a little bit working, I'm sort of on board of trustees, but I'm not working in the details. Here you can see this coordination office takes sort of the burden from the GP to organize all that and to do the fine-tuning. So they get a referral and they give the patient a broad overview over intervention offers. And the board network of prevention has contact to lots of stakeholders. Now there were almost 80 altogether. I mean, doctors, therapists. It's not only people working in healthcare, but it's also social care and things like that. A lot of different groups who are working in that field. And they give the patient a very good information on it, and then they fix the goal and the intervention practically. So if the patient and the coordination office agrees to send the patient somewhere, they even call it up, they give them a special date to go there, so everything is set for the patient, agreement with the patient. Now, what type of health interventions? That's a nice picture Sabrina gave me. You know, looks very green and optimistic. So it is nutrition. They have meetings with dietitians, and they get a program for the diet. Then quitting smoking is a very big issue for most of those patients. Physical activity. There are lots of sports groups who offer physical activity for those patients, but in this institute I'm working at, we have now employed a special sports exercise therapist, and this is a person coming from sports science and now working with this institute. Then management of addictions, sexual health, psychosocial support. Hypertension program. We have a Herzmobil would be heart program, mobile heart program, and this includes heart failure, hypertension, and coronary cardiac disease. But now the focus is in the prevention program is on hypertension mainly. Now, if the person is at this destination, let's put it this way, okay, then the process is continued. There are follow-ups with the coordination. They call him and say everything, or her, is everything all right? Do you need anything? So it's a sort of a personal coaching too. And then there are follow-ups also at the GPs, and then they can decide whether they're going to continue this or they need a different intervention, or maybe there is a medical issue arising where the person, because of which the person can't participate anymore. This would be a good point to say exclusion criteria are usually that the person is in need of more or less intensive medication. And another would be that the person is not mentally capable to participate in that pathway. Now, where do we stand now? First of all, I want to say now, at the very moment, it's a pilot project, and there are 9 MDs, GPs, participating with their partners, so there are more GPs. And then now we have enrolled so far about 50 patients. So we are at the start of it. This is the pilot phase, as it is called. What we try to achieve too is to have a prevention record, which is in planning. We have, in Austria, we have an electronic health record, but it is mainly used by the hospitals and the residential doctors, and also it's possible to access by long-term care and some therapists, but this is only evolving. Evaluation is ongoing. There is a special team. Sabrina could tell you a lot more because she is a specialist in statistics and evaluation. And what is interesting on this slide at the end, so far we have got no special funding. We tried to do that, but it is difficult. But on the other side, most of those participating, they get some funding somewhere else. Okay, so sports group, they get some funding from other sources, so to speak. If you are more interested, this is the coordinator. She's a nurse and a sports scientist in one person, and she's sort of the head of this prevention pathway. Here are the contacts. And there are some posters we also present from this Tyrolean Federal Initiative Institute for Integrated Care. Thank you very much, and questions and answers, I hope I can give them to you. Thank you very much.
I'm just going to check. It is working. Excellent. So guys, you have been very quiet on the Q&A. There are no questions coming in. So come on, get your fingers tapping and let's get some questions, or give us some straight from the audience. Stick your hands up. Oh, excellent. See the panel are stepping into the breach here. We help each other out. Do you see that? Integrated care in action. Yeah.
Well, I have a question. Thank you very much for that wonderful presentation. But the funding, how do you see that in the future? Are the social insurance ready to pay for it? And is that the payment within a public health situation, or is it rather in a reimbursement system?
Okay, I think that's a very good question. Yeah, the thing is, first of all, it is sometimes difficult for federal government things to get funding from social security system, and the social security system and the insurers, they have their own things they want to do, but they don't have anything like that so far. And in the Tirol, we also have a coordinating board with all social security providers and everybody in there. So we try to go this way. Another problem is that they are still working on a prevention strategy. And I think the thing is that they really want to have a very inclusive prevention system for every possibility. And this is so complicated, and life changes so much for most of the people. So this also takes time. We are hoping that we get finance for the coordination, and then we are also hoping that those partners which don't get any money, okay, no funding, they'll get some funding. That's our perspective.
Great. Thank you. Thank you to Gabrielle and John E. Excellent. Do you want to add? Are you Gabrielle? Gabrielle? You're not? Okay, well, I'll start with Gabrielle, but I've seen you. I'll come back to you. So Gabrielle asks, beyond funding, what potential challenges do you see in the scale-up of the prevention pathway pilot? Good question.
Okay, the prevention pathway pilot is financed. Okay, so it is financed the way I told you. It is the way that most of them, they get some funding, and they are so interested to participate, and so it's so welcome, this pathway, especially by the doctors, but also by almost all of our partners. They now do a little bit sort of in advance. They are themselves investing a little bit in this pathway, and so, well, they have some funding, but not enough, and so this is the way we finance now, indirectly at least, this pathway.
Thank you. And John E. asks, are there any children or adolescent clients in the pilot?
No, not yet. This is not for children at the moment.
Thank you very much. Yourself. Just hold on 1 second.
Wait, I did.
Yeah, there you go. Thanks, Lee.
Thank you. I was just wondering, I missed the start of your presentation, which is a shame, I'm sorry. But is this pilot and this program only open to patients that already have some medical needs, or is it also open to people who do not have medical needs or are not aware of their medical needs, and can they also start with the program?
Okay, it's not a shame that you came so late. Okay, at the very beginning, there is always this health checkup at the GP. Okay, so that's the entrance to the pathway. This is absolutely net. And there they define health potentials. Now, I know people with special medical needs, they are excluded if it's too much. But hypertension is a very good example. Okay, when does it start? So those people are in this pathway too. And then we also have a special pathway for long-term hypertension, which means that they are really deep into hypertension. But on the other hand, like obesity, obesity is a real medical problem, and it is also a disease. So what should we do? And I think we all integrate them. Okay, so it's in my eyes, this definition is very difficult to say needs or not needs, medical conditions or not. I think it is in the interest of the or in the aim or in the spectrum of the GP plus the patient, and then the coordination of it to define that and see what potentials we have and what we can do for them, and not stick to the complex rules.
Thank you. And now, John E., you're on fire. Question number 2. Where is the gap in funding? Is the coordinator, for example, funded?
Yes, the coordinator is funded, and it is done by the person working in this institute. But at the very beginning, she was working for heart failure program, and now we limited this work a little bit, and she got a percentage to work for this pilot project. But originally, she was for heart failure project, and then she filled in for a palliative care project because another person was on education. So this is the way we just try to figure it and to puzzle it in.
And just another quick 2, and then we'll move on to the next speaker. Does the prevention pathway focus on a specific target group?
No. It is entrance is health check, GP, no target group.
Thank you. And last one then is, can you tell us about the time perspective of the project? When did it start and when do you plan to finish the pilot?
The first patients were in the program in the middle of March. And I'm not absolutely sure about, but I think it will be ongoing for about 6 or 9 months. I'm unfortunate, I don't have that information.
Well, thank you. And you did step in at the last minute, and I'm sure you would agree he did a fantastic job. So if you wouldn't mind just putting your hands together for Johannes. So I hope that presentation has warmed you up and that you're now getting really into thinking about really good questions to ask each of the speakers and the panel. So I'll be keeping an eye out, but I'm keeping an eye out in the room as well. So don't be afraid. There's no such thing as a stupid question. There's only really good questions and curiosity, which is what integrated care is all about. So with very great pleasure, I would like to introduce you to the next speaker, Dr. Jan van Emelen, who is going to speak to us about community-based COVID vaccination. Thank you very much. Over to Jan.
Thank you very much. I'm absolutely honored, and I try to progress the slides. Do I have to do something specific, or I don't see anything? Very shortly. Oh, yeah. Okay. Thank you very much, and I'm absolutely honored to present you the results of the community-based COVID vaccination in Flanders. I'm Jan van Emelen. I'm a medical doctor, but I've been working the first 15 years of my career in Africa, in Central Africa, a lot of prevention we try to do. Then afterwards, I was a civil servant in Belgium, also a lot of prevention to do. I was politically active, and then I was active in the social insurance. But the last 3 years, I was involved in the management team together with Dr. Sven Beersmans, who is present, together with Peter Porriot, the general manager of the vaccination team, and with San Seges. And I'm absolutely glad to present you the results. In what framework have we been working? Social insurance versus health approach, and vaccination strategy central in Flanders, and what is the future? And I'm absolutely glad with the first speaker who presented a real prevention center. That's the way we want to evolve with the vaccination center. Flanders has been organized with 60 primary healthcare units, and you see in light blue the primary healthcare unit where we have been working in the vaccination center. So each primary healthcare center was foreseen with at least one vaccination center. In that Voorkempen, in that unit of care, there were 6 communities with which we have been working very intensely together, with a total population of 110,000 people. And if we compare that, the Flemish region is 6.6 million people. So it was very representative in the central of Flanders. Strategy was double, a central level, individual invitations by mail, by post, logistic and financial support, IT support for the agenda management and registration, so a strong central management, but at the local level, we had also a very strong management team responsible for communication, responsible for the operational organization. And we have been working very strongly together with the communities. It was the first time in Belgium, I think, that there was so intense cooperation with the management team. And we had the initial goal was to cover 70% of the population that had to be covered. And we have been able to reach 95% of the population with at least 3 vaccines. How has this been realized? Nobody expected this. What are the success factors of these experiences? First of all, creating trust. It was the most important thing. Trust towards the GPs, trust towards the institutions, with a uniform communications towards press and population, hospitals, care homes, and primary care providers. Very important that it is a standardized communication system, and also a standardized training of the GPs, and nurses and volunteers, and standardized operations. Secondly, optimal cooperation of the vaccination center with the GPs who could vaccine people at home. It was an opportunity, or it was a possibility, but the majority was done in the vaccination center. Cooperation with the local nurses, the pharmacists, the communities, volunteers, and the training, and mobilization, coaching, daily briefing of the volunteers. Quite important. And third of all, the principles of population management. So the identification of who is the population by priorities to vaccine. Secondly, setting up the targets, the goals, and the operations, and assessment of the results and adjustment of the operational approach. Success factors. Certainly the very flexible management day by day by a limited number of managers, not in a talking way, but in a do way, and that's quite important. With daily meetings, briefings, coaching, and quick decision-making so that the operational activities were guaranteed. Secondly, the support of the municipalities with accountancy, with logistic support, and also communication, and mobilization of local volunteers. It was overwhelming. We had 1,600 candidates, and between them we have been working regularly with 400 of them, and it was a quite interesting experience. The costs per vaccination are different if you compare Flanders with Wallonie, with Brussels, and with the German-speaking parts of Belgium. In Flanders, the cost was 64.79. If we compare our costs per vaccine, we have been able to give 300,000 vaccines for a cost of €8 per vaccine. So it is absolutely very, very low. And our proposal today is we have to evolve towards a real prevention center, structured, permanent prevention center. The broad experiences can be used to improve preventive actions and early detection programs in different domains, just as is the case in Tirol. It can be used for infectious disease, including influenza. If we see the actual results of the influenza vaccination campaign operated by or worked out by the GPs, then we achieve 65% of the target population that has been vaccinated in the past year. How can we improve that figure? Next vaccination who is coming is RSV, respiratory syncytial virus, also pneumococcal, different 3 vaccines actually on the market. The focus has to be the risk population, and there we can enhance absolutely the figures. Chronic diseases with early detection, it was exactly the same that we aim. It's not the pathology itself, but it's the risk, the opportunities for health is the risk management and the risk identification. And instead of just insuring the risk, we should be able, with a prevention center, to manage the risks. And that's very interesting, even for patients and for the systems. Improvement of the oncological screening programs. We have classical obligatory screening programs of 3 cancers. We have a participation of 60–65% maximum. It's not that much, and we can improve it easily. Geriatric stratification, and then I'm looking to Japan, where the stratification is done by the municipality, with very interesting results in terms of what are the risks and how can we manage frailty or the risk for frailty in time. And finally, mental health, early detection at population level is absolutely worth to make further research in that domain. What kind of structure should we realize for the permanent switch? It's obvious that there is a political decision necessary, a legal framework, structural support, and a budget. If we see the budget, WHO pretend that 5% of the healthcare budget should be oriented towards prevention. In the EU, it is actually 2.9. In Belgium, it's 1.6. It's very, very low. So there is room for improvement. Specific structure owned and managed by GPs is a very interesting possibility with a broad integrated health concept, business plan targets in consultation with a central level, and that's also discussing how can we fund it. So I want to thank you in the name of the WHO management team who is present, and I'm absolutely glad to answer your questions. Thank you.
Thank you very much, Jan. That was really interesting. So we only have one question in. I'm sure you have lots of burning questions, so type them into the Q&A and I'll make sure that we ask them. But I'm accumulating some questions for the panel discussion. I don't know about you. But the first question, Jan, is how did you identify the target groups for focus on vaccinating?
Yeah, that's a very important question. The target groups were defined centrally. What are the priorities? People who are taking immunocompromising treatments. So we had to identify them. And it was a cooperation with the GPs who were able to identify themselves an individual, but also the hospital had that possibility to identify. So it was a kind of have we enough people with this type of cancer? Have we enough people with rheumatoid arthritis that are vaccinated, yes or not? So it was a kind of population management that we tried out. But it's very important that we develop further on the population management in terms of not only individual approach, but the population level.
Yeah, and there's certainly plenty over the course of this conference on taking a more population health approach to how we think, plan, design, implement and evaluate. So thank you. Next question. Oh gosh, you've been busy. You've been busy while I've been asking the question. Thank you. Okay, so question, was this early in the pandemic?
We started the vaccination in March 21, when the vaccines were available. The first vaccine, we started the first shift of 80 patients, I think 80 persons were vaccinated, and we ended in December 22 with, at that moment, 3,000 vaccines a day.
Oh, gosh. Okay, next question. Can you elaborate the geriatric stratification, please?
Well, I think it's quite important that we can start in Japan. The community and the GPs who are living in the communities are working out the standardized stratification from the total population starting at the age of 40 years old. And then people are clustered in 7 clusters. The 2 first ones, there is absolutely no support needed. The next 5 clusters, there is a progressive improving support so that risks can be identified very early and that the total cost of care can be controlled by this kind of exercise. It is Japan, it's a different culture, it's difficult to compare, but I think we have to learn a lot of this kind of approach. It is exactly the same as the Tyrolean pathway in terms of identifying very early any risk, any health opportunity, and going structurally in that way.
Thank you very much. Next question is, how did you identify the communities you worked with and how did you ensure representativeness? How were local volunteers recruited and remunerated?
There was a workshop created, population management, together with the communities. And we had a kind of central feedback of the registered vaccine, so that we could identify very detailed in a map where are the different streets or environments where the vaccination rate is too low, and how can we enhance that by the local community workers, social workers, even the mayor was included.
Excellent, thank you. Did you have concrete plans already to become a prevention centre?
We had concrete plans, but it is not easy to work it out immediately. We have to have the local agreements with the GPs, with the unit, the healthcare unit, with government. We have plans to install collective vaccinations for flu. It's very easy to organize. With an increase of the results, actually the results are 65% of the target population who is vaccinated. We can improve it easily until 90% with a population management and with the cooperation of the communities. We are absolutely convinced that that is a possibility. And I'm absolutely pleading for a health technology assessment in the broad significance of the idea is, with a simple financing of 2 persons central for each health unit, we can install in cooperation with the GPs, a kind of population management, and we have to calculate what is the win of this for the system. I'm absolutely convinced that we can do a lot of win situations.
Yes, excellent. So just one last question is, how is Flanders going to move to 5% for prevention? I was thinking the same thing about Ireland. How can we possibly get to 5%?
We are asking exactly the same question.
So thank you very much for the questions, and thank you very much, Jan. Please put your hands together to recognise Jan's presentation. Thank you. Okay, so our next speaker is Maria, who is, not that I have any preference or bias of any description, but she's from Ireland, yay! So, Maria, we're very pleased to welcome you today, and we look forward to your presentation on strategies for integrating Making Every Contact Count programme in the Irish Health Service. Thank you, Maria.
So good morning, or afternoon nearly, everybody. I'm delighted to be here today to talk to you about strategies for integrating the Making Every Contact Count programme in the Irish Health Service. I'm currently working as the Service Improvement Lead for the Integrated Care Programme in Chronic Disease, but from 2016 to 2020 I held the role as the lead for the Making Every Contact Count programme in Ireland. So I was delighted when Anya mentioned that we had a little bit of extra time today, because what I'm going to talk to you about is a research project where we've looked at identifying the strategies to upscale and implement the programme across the health service. But in order to do that, I feel it's important that I give you a flavour or an outline of what happened up until probably 2019 in terms of the programme. So when Anya mentioned that we had a little bit of extra time, I was delighted that I could spend a little bit more than just this one slide giving you an outline of what the Making Every Contact Count programme is, and I suppose the work that went on that led to this research project. So I suppose the Making Every Contact Count programme is a programme, I suppose, primarily focused on chronic disease prevention and management by trying to implement brief interventions for lifestyle behaviour change as part of routine clinical care within the Irish Health Service, right across the country. So we focused on looking at smoking, alcohol, physical activity and healthy eating as kind of the 4 main topics. And I suppose it was really about trying to bring about, in a strategic and coordinated way, the culture change across how our services were delivered in Ireland, so that healthcare professionals would recognise and understand the opportunities that they have to support their patients around lifestyle behaviour change with every interaction that they have with them. So as I said, this work started in 2016, And I suppose up until then, there had been pockets of work across the Irish Health Service where brief interventions were being delivered as part of care, but maybe just to do with smoking or maybe just to do with alcohol. But there was what we were trying to do with this programme was to create a coordinated strategic approach to how that was happening. And I suppose the first thing that we did in order to make that happen was develop a national framework and implementation plan, which was really important, I suppose, in terms of setting the scene, the shared vision, and the objectives of what the programme was going to achieve over the coming years. And I suppose what was really important about the Making Every Contact Count programme and the approach at this time was that there was a decision made within the Irish Health Service that this was a key strategic priority to look at chronic disease prevention and management and how we actually embedded that and how we delivered our services. So that was a huge, I suppose, support and enabler to implementing the programme as well. Once we had, I suppose, the framework and the implementation plan developed, we then realised that there was a couple of key enablers that were missing that we needed to develop and put in place so that we could look to implement the programme across the country. So the first piece was a national standardised training programme to be developed and rolled out across the country, which we did. And it consists of a series of 8 e-learning modules and which staff can complete online on our learning platform. But in addition to that then, anybody who completes the training programme is invited to attend, I suppose, a skills development workshop where they get to, I suppose, develop and hone their skills. So that was being rolled out across the country. And I suppose there was a very small central team on which I worked on, and there was a number of people worked on it with me. But we needed an army of people across the country to be able to actually roll out this training programme and to be our agents of change and our, I suppose, what do we call them, champions on the ground. So I suppose we were very lucky that also within the HSE and the Health Service Executive at that time, there was agreement that our workforce of health and wellbeing officers across the country were also, I suppose, identified as a key group of people who would support the implementation of the programme across the country and across health services. Some of the other work that we did, we looked at a standard national undergraduate curriculum for healthcare professionals to train our healthcare professionals of the future, and that's being rolled out across all of the institutions across Ireland at this point, and it's for all healthcare professionals, so for doctors, nurses and health and social care professionals as well, and that's working very well. And the other piece, I suppose, that we wanted to do was develop a method of documenting or recording that a brief intervention or a Making Every Contact Count intervention was delivered as part of services, and that it would be incorporated into patient records. So, you know, we've heard this morning again the challenges of having shared record and electronic health records. We too share that challenge in Ireland still currently and are working towards having an electronic record. And I suppose one of the key pieces that's important is that the Making Every Contact Count record will be incorporated into anything that's developed, but currently that's just recorded in a paper format. And I suppose once we got to that point, then we needed to start actually getting some work on the ground happening and having Making Every Contact Count implemented. So back in 2018, we identified an initial 100 sites across the country who our health and wellbeing staff would support to implement Making Every Contact Count as part of their routine work. And that was, I suppose, then into early 2020 when COVID hit, which obviously had a huge impact on the implementation of the programme with staff redeployed and all of that. But I suppose we've been recovering from that in the last 12 months, and that's actually been working quite well. I suppose simultaneously what had happened was we had been looking at the research and looking at the evidence that was there to see could we inform how we upscaled and implemented such a programme at a large scale across the country. And while there was significant evidence for the evidence of brief interventions and the effectiveness of it, there really wasn't a huge amount of evidence in terms of upscaling a programme like this at national scale or at any large scale. So we, I suppose, decided to try and create some of the evidence ourselves and investigate what the strategies and what the barriers and enablers were to help identify the strategies to take it forward. So the website at the end of the page there, just makingeverycontactcount.ie, that's if you want to actually get any further information on, I suppose, some of the other pieces that I've talked about in terms of the framework, the training programme, I direct you to that, and that will give you some more information on that. suppose one of the key things that happened in 2020 as well was that making every contact count was integrated as part of our model of care for the prevention and management of chronic disease. So that's setting out that making every contact count is to be delivered at every level. So not only just at the prevention level, but also within general practice, within our community-based services, and also in our acute services. And I think going forward, that's going to be a key strategic piece in terms of embedding the programme across our services. So that leads me to tell you a little bit about the research project that we then got involved in, which commenced in 2020, to look at identifying the barriers and enablers to implementing the MEC programme across the Irish Health Service and how we went about that. So we had, I suppose, from the health service perspective, been involved with our academic collaborators in National University of Galway, and the Health Behaviour Change Research Group there had been working with us, I suppose, at different stages throughout the programme, so we'd well-established relationships there. So we embarked on a joint programme of work to look at identifying the barriers and enablers, and outlining there, I suppose, is the research team, which was led by Professor Molly Byrne, who's the head of the Health Behaviour Change Research Group there in Galway. The aim of the project, I suppose, was to identify the barriers and enablers, but to use that to develop an implementation strategy to optimise and scale up making every contact count in Ireland. We broke the research programme down into 3 work packages. The first one looking at mapping the barriers and enablers to MEC, and I'm going to talk to you about some of the results that we achieved there. The second work package was around understanding patient attitudes and experiences, and that piece of work is actually just coming to the end of the research phase. So unfortunately, I don't have results to present to you on that, but we will be publishing that in the coming months. So I'm happy to share that with anybody who'd be interested in the coming while. The third work package then, I suppose, was looking at the development of a collaborative implementation strategy. And that was, I suppose, looking at having identified the barriers and enablers, how we could work with the health service and with the implementation element of the health service to actually identify strategies to scale up the programme. So the first work package, as I mentioned, was about looking at the barriers and enablers to MEC implementation. So a survey was carried out with all the healthcare professionals that had completed the training programme up to that point. And I suppose everybody was offered the opportunity to participate. Again, I suppose COVID impacted on the participation or the response rate here, but we still achieved, I suppose, what we were, a really good response rate in terms of, I suppose, identifying what we needed to identify from a research perspective. So this is just giving a little profile of the I suppose, details of the respondents that took part in that survey. And it was particularly nurses, physiotherapists and midwives were primarily the group of people who participated in that. And I suppose what was really important from that was that 30% of the people who had actually participated in that piece of work had actually not only completed our e-learning programme, but followed on to attend our skills workshop, which was actually a really interesting finding. And then the other piece coming from that was what we discovered was that typically participants who delivered making every contact count did so only just over half of the time with half of their patients. So that was an interesting finding. It was like, well, why aren't they being delivered with 100% of their patients, and try and identify kind of what some of the reasons that was happening. And then the other interesting finding from that piece was what interventions were being delivered. So physical activity and healthy eating, smoking were primarily the interventions being delivered, but less so interventions around alcohol. And I suppose we were interested to kind of unpeel some of that and discover maybe what some of the barriers to implementing or delivering interventions on alcohol were. So the second part of that research piece was to look at interviews with a number of the healthcare workers who had completed that survey, and to try and see, could we identify what were the actual themes or factors coming from that. So we used the theoretical domains framework as a kind of a research design in terms of doing that, and we had, I suppose, 14 domains which we explored with the workers and staff as we went through that process. So this slide here is presenting, I suppose, the barriers and enablers to MEC delivery, which were identified from that, using that theoretical domains framework. So I suppose an odds ratio over 1 is kind of showing that the more say, for example, the more knowledge that people had, the more positive that was in terms of determining whether people delivered an intervention or not. And then things like an odds ratio less than 1, say, for example, the barriers to prioritisation. So that would be looking at maybe it wasn't being prioritised as part of the service, that was actually impacting, and I suppose negatively impacting on the implementation of the programme within services. So I suppose knowledge, skills, professional role, beliefs about their capabilities, and I suppose having optimistic beliefs about the consequences of doing an intervention, believing that it was worthwhile to do it, were some of the top pieces that were top factors that were identified there as impacting on the delivery of the programme. But interestingly, intentions and goals, and I suppose having an understanding of what the patient's intentions and goals were, was identified as the top factor there impacting on MEC delivery, and whether they believed that the patient had an intention or a goal of making a behaviour change. So I suppose indicating there that there was work needed in terms of working with staff to not make their own judgments around those intentions and goals. And then the other piece that we did was we looked at the confidence interval-based estimates of relevance to see which of these were the most relevant in terms of impacting on the implementation of the programme, so that we could maybe use that then to try and identify strategies to overcome some of those barriers. So the key, I suppose, pieces there were intentions and goals, barrier to prioritisation, environmental context and resources. So that's, I suppose, the environment, whether it supported it within the service, and whether there were resources. So, for example, if you did an intervention with the patient, did you know did you have resources available to refer people around social prescribing, access to local services and those kind of supports. Beliefs about the capabilities, negative emotions and skills. So we also, I suppose, then did a bit of multivariate analysis to try and answer two questions. So could we determine what were the main predictors of a healthcare professional delivering a MEC intervention? So I suppose their understanding of their own professional role, again, the intentions and goal coming up there very strongly, and I suppose having negative emotions, I suppose, was kind of looked as a barrier. So their own emotions around a particular health behaviour maybe, or their own negative emotions around the effectiveness of how effective an intervention might be. Then we also looked at, was there some way we could predict, again, the frequency of how often an intervention was delivered, and you can see, again, similar findings there. So taking all of those findings from the work package 1, we then, I suppose, embarked on a consensus process with our key stakeholders to try and see could we develop collectively and collaboratively and design some implementation strategies that could be employed and deployed across the country to scale up the programme. And we did this in a number of ways. We did an online consultation survey to identify, I suppose, some themes. We then looked at, I suppose, those recommendations and classed them based on the COM-B model from Susan Michie, looking at capability, opportunity and motivation. And then we brought all of those stakeholders together in as much as we could to do a 2-day stakeholder consensus workshop to develop the recommendations to take the programme forward. So these are, I suppose, the key recommendations, the top 9 recommendations, and there are more, but these were the top 9, based on the evidence, based on what we were hearing from the research as to what would actually support and enhance Making Every Contact Count implementation across Ireland. So first, providing dedicated time to practitioners to attend the training and to use MEC. Management and senior staff have responsibility and accountability for the MEC delivery, so that was actually something that would have to be reported on in terms of activity metrics. To measure and record MEC delivery, so that's having a MEC record or some sort of a MEC patient record as part of patient record and patient files. Having service directories for healthcare professionals to refer, so delivering a MEC intervention is one thing, but having somewhere and having a resource available that would give them the information to refer patients on to local supports in the community or to social prescribing initiatives. To have local MEC champions, so having people on the ground around the country in different areas to support staff in terms of delivering MEC interventions as part of their work. Have a dedicated resource centre on the MEC website, again, that's something we're in the process of developing. have a national communications campaign to promote MEC to staff, but also to patients. And I suppose this was something that we thought would be really important, so that patients understand that this is now an agreed way of how we're delivering our services, and that it's about us supporting them in the prevention agenda. Generating and highlighting evidence for MEC impact on patients, again, I suppose the continued need for research into that, and enhancing MEC in our undergraduate curriculum programme. So while I said we've developed a curriculum, it's about further enhancing and embedding that. So I suppose the next steps, policy briefing has been prepared from the research work that's been carried out, presented to senior management across the HSE. We've engaged with the MEC programme implementation team to develop a new strategy in terms of taking the programme forward from 2023 to the next 3 years, and that's in progress. And the other thing that's really important, I suppose, from the research piece was to publish the research findings in peer-reviewed journals, to create the evidence base and to share the learning and the experiences that we've had. Because, as I said, it's something that we really struggled with because we couldn't find it in terms of implementing a programme at scale. And so I suppose from that point of view, it's really important for us to share that. And that's something that will be happening over the next couple of months. There are a few journal articles pending final sign-off with a number of journals. So the International Journal of Implementation Science and the European Journal of Health Behaviour Change. So we'll coming to you soon in a journal. So look, that's just to thank you for everybody for your attention. That's my details. If you have any further queries or questions that I can't answer today, feel free to contact me, and I'll respond when I can.
Thanks, Maria. Thank you very much, Maria. It's always a pleasure to hear about the MEC and the Chronic Disease Programme. You've gone very quiet on the Q&A again. You must be getting tired. The thumbs must be getting weary. But come on, we're on the home stretch. So if you have any questions for Maria, please let us know. Oh, we have a question at the back, Niamh. Is there a roving mic? Back left. Yeah. You would have to have it. I would admire your lungs if you're able to do that.
You're preventing diabetes by walking so much.
It's edgy. Her step count is going to be right up there.
That's it. So thank you for that lovely presentation. I have a question. If you could just give us more detail about what the training comprised of the making every encounter count. Skills, competencies, motivational interviewing, behavior design, what did that look like? And then my second question is, how did you work with all of the undergraduate programs to ensure competencies mapped for, say, for example, schools of nursing and their accreditation process? Thank you.
Okay, so the first piece, I suppose, maybe just the website that's on the slides. If you want to go there, you can actually check out in detail the training programme, but I suppose, yeah, just to give you a brief outlining. So the programme did look at brief interventional skills. It looked at, I suppose, the whole patient-centred approach to behaviour change and doing that in a patient-centred way. So we used the 5 A's framework for a brief intervention was kind of the skills construct under which we developed the programme. And then there was a kind of a core module around that. Then there was 6 topic modules. So we had a topic module around healthy eating, physical activity, alcohol, tobacco, and later came one around mental well-being and then around weight management as well. But I suppose the key things of those the key aspect of each of those modules was it was about giving information, but it was also about embedding the skills approach of the 5 A's in each of those topics. So how to empower the healthcare profession to be able to use the 5 A's to talk about that particular topic. And then we did do at the end was almost a kind of a skills demonstration where we recorded a whole series of videos of healthcare professionals delivering brief interventions so that they would actually see models of good practice in terms of how to do that. And as a follow-on then, they could come to the skills workshop, which was face-to-face, which went virtually for a while with COVID, but it was still worked really well so that they could actually, I suppose, come to a half-day workshop to develop those skills and practice those skills in a safe environment. The second piece around the institutions and the undergraduate curriculum, So I suppose back in about the end of 2016, we actually wrote to all the schools of medicine and nursing and brought a collaborative group together, which then met once a month for 3 years to develop not only just a Making Every Contact Count curriculum, that was part one, but the second part of the curriculum was self-management support for chronic disease. So it's part one of a two-part package. We brought them all together. I suppose it was a really interesting piece of work because it was the first time, to my knowledge, that we brought institutions together at that level to try and develop a coordinated standard approach. Part of the development of the curriculum was that we, I suppose, linked with our national registration bodies in terms of mapping the competencies and the skills into the core competency skills that were set out for not only our healthcare professionals but also for undergraduate and graduate programs. So that was, I suppose, how we kind of did that. In terms of implementation, it wasn't a standalone block of, like, I think it's 20 hours maybe is the curriculum content, but we didn't take it as a block and say this has to be put in as it is. So it was up to each program to then decide where the different parts of the curriculum actually fitted and integrated within the nursing curriculum, the medical curriculum, the physiotherapy curriculum, whichever way it was. And that was, I suppose, how that worked really well, because it gave them the opportunity to embed it best within their programme, where it's at.
Okay, great. Thank you very much. Any other questions for Maria? Just one in the middle. Thanks, Niamh.
Great, thanks. I did post it on the thing. Maybe refresh, I don't know. It's on there, but it doesn't matter.
We'd much rather hear your voice.
Yeah, all right, okay. That's fantastic, Maria, like such a huge body of work, and I love the approach that you take, like using a really robust scientific lens with using the TDF and the COM-B frameworks. My question is, at what stage are you looking at actual patient outcomes by whatever metrics that you're using? So is it actually working? Is it helping? Is it making a difference?
Yeah, so I suppose that's where having a record, so being able to track if patients are actually doing that. We have looked at it in terms of the GP practices and the GP programme, which is being delivered for chronic disease management at the moment, and it's really making a difference. So while I suppose GP practice in Ireland is a privately delivered service, so we have been working around delivering the chronic disease management programme, which is a new programme around the support of people with chronic diseases there. So we have some really good patient outcome data coming from a report that was only published since January. I don't know the exact date, I think it was launched in February. And looking at, I suppose the chronic disease management programme is for patients with chronic disease. They have a set plan of care, and what we've been able to do since the programme was implemented in 2020 is now look at the pattern of improvement for those patients around lifestyle, particularly looking at tobacco, healthy eating. There's been some really, really good results. I don't have the figures off the top of my head, but if you want the link to the program, to the report, I can drop me an email and I'll give you the link to it. So I suppose we have a way and a mechanism of doing that. How we have a mechanism of doing that in the GP practices is because the record is embedded within the GP electronic system, and we can track over time the changes, because obviously we can see that and see the change and see that it's working. We don't have the same luxury yet within community services, but we are looking at developing a community-based health record, and that's why we want to embed the record within that, to be able to do exactly what you've asked, is to track patient outcomes and benefits in relation to that.
Great, thanks.
Thank you. And yes, you're quite right. It's right there. And a few other questions. I'm really sorry. I have accused you in the wrong. You have been typing away. I just didn't see them. Apologies. So, Maria, there's a number of questions, but I'm going to pick out one because I think it would be really interesting to move on to a panel discussion. And I'll pick up on some of the questions I haven't yet asked in the panel discussion, so I won't forget about you, don't worry. Could you elaborate on why usage of alcohol and drugs was less frequently intervened on? Expectation of poor results or negative emotion?
Okay, so I think some of it was to do with the level of comfort of the healthcare professionals themselves in terms of raising the issue of alcohol. It's definitely of alcohol and weight management are the two where we would have seen the highest level of discomfort in terms of raising that issue. So I think that was part of that. And the second piece of that was around the negative emotions, was it?
Expectation of poor results or negative emotion?
Yeah, so I suppose that's coming down to back to the healthcare professional maybe expecting that raising that particular topic maybe won't actually make a change in the patient. So I think that was kind of identifying for us. There's a little bit more work that we have to do in terms of working with healthcare professionals to understand that no matter how small the change is, it's worth doing, and not to make the judgment. That's the whole piece of the non-judgmental piece, that it isn't about making that judgment. You might not see the change. It might happen 6 months down the line and you might not realise you've had anything to do with it, but you still need to take the opportunity to do that. So I think that was kind of one of the focuses of some of our campaign going forward, will be around highlighting that to healthcare professionals.
Super, thank you very much. So as we move on to a panel discussion, please put in your questions. But I will open the panel discussion. So it's really great to see the amount of presentations and discussion around prevention really taking off from an integrated care point of view, but also more generally in health and care systems. But I've always felt that it's easy to say, but hard to do. So panel, should we give prevention not just parity, but primacy? Discuss.
Okay, I would favor this approach, yes. And I think it is sort of, prevention has always been in the background and it has to move in the foreground. The other part won't lose that much if prevention is put in the foreground. And I think with the development of population and diseases and so on and so forth, it's our only chance to have our health system survive.
I'm absolutely convinced we have a shortage of caring people. We have hospitals with 20% less activities than before. And the evolution, the demographic evolution, as we see and as we expect will be till 2050, 2060, will be a very huge pressure on the care system. So I'm absolutely convinced that together with prevention systems and rather risk management than risk insurance, we should manage more the risks and we should invest in informal carers. We have a lot of informal carers who are able to do very high specific techniques, who can be trained for IT, who can be trained for mobile health, and who can be trained for collective activities for chronic diseases. So I think there are a lot of opportunities that we see for prevention and for a transformation of the healthcare system and allowing informal carers to do some acts.
Thank you, Jan. Maria?
Obviously, I'd agree. I think we should give it primacy. I think the bit around, I think what's important to acknowledge is that there's actually quite a lot of prevention work happening. Everybody's aware of that. I think some of the next steps that we need to do are joining those pieces up and maybe connecting them and giving them strength in that way, because sometimes it's a little bit disjointed, and I think by joining it together it'll give it the strength that it needs to take its position in primacy. So I think that would be important.
Thank you very much. Any questions from the floor? Because I've got lots. Any? You're happy for me to just keep firing my questions? Okay, but please put your hand up if you have any. I don't see any coming through there. So I did notice that a number of the interventions that we've talked about are around GPs. So my personal view is that we're over-medicalising a lot of these things. So how can we shift further left into the community and even outside of primary care, but into community care. You mentioned that municipalities were taking on risk stratification. So what are the panel's views on really shifting left and keeping left?
Okay, I start off. First of all, I have to thank Sabrina. She is now coming. She came.
Well done, Sabrina.
Okay.
He did a great job.
Okay, now, first of all, I want to say that the trust in the GP is still very high, and people tend to go there. And community nursing, I mean in the sense of advanced nurse practitioner, in the sense of prevention, you know, is in Austria at least, is not that well established. It is only beginning. And it's also with the other health professionals that the patient has to trust them. But we need to transform that. We need to transform like informal care, okay, the neighborhoods and things like that. We're going to talk about that tomorrow and the day after tomorrow. This is necessary, but it takes time. So I think that that we still have to leave the GP in the position, but gradually we have to move on to different professions and to the community and the peer groups, especially for the young ones. You know, they don't listen to the doctor, they don't listen to the nurse, they listen to their peer groups.
Absolutely.
And I think this is something where you can encourage young people to be a peer in the classroom and so on and so forth. And this would be an approach from the bottom up.
Thank you very much.
Yeah, I agree that for the younger people there is a different approach compared to the people from 50, 54. But I think that the general practitioners play always a central role in fixing together with the patient his goals. We saw it this morning, Jan'21 and Jim talking about the goals. I'm absolutely convinced that we should go further in this direction, and that the GP plays the central role together with the patient to identify what are your goals, and then identify what are the objectives and what is the action plan, and there you go towards a decentralization. But the GP is in the center of the decision of the goals. That's what I think.
I would be inclined to think that the patient is at the center, but
together with the patient.
Okay. Maria, please.
I suppose in terms of true prevention, it would be really good that we had, I suppose, very strong community supports, peer supports, where people could access them in a self-directed way, in a patient-centred way. I suppose at the moment, we're in our services, people who come to our services are coming for a reason. There's maybe have a problem, there's something wrong, and I think we need to continue to support those people, particularly in terms of chronic disease prevention and secondary prevention in terms of supporting people who have existing chronic diseases and the impact that prevention can make on those. So I think we do need to continue to do that. But catching people before they actually get to that point is obviously the golden nugget. So it's about focusing on, I suppose, strategies and ways to actually do that and providing supports at local level and creating that awareness, and particularly, say, for young people who maybe aren't engaging in health services at all because they don't have any need to, but I suppose trying to capture their attention in a way. So, you know, social media is probably how we have to do it, and we'll have to get a bit more savvy at it than we have.
Indeed.
For the young people,
Yep.
I'd like to stress the fact that the schools and the education can
And
play
that
a
very
quite
nicely
important
leads
role.
me on to a
I
question
was,
from the audience.
As coordination in the vaccination center, we went to the schools and we give them lessons on virology and biology. And I was amazed about the lack of knowledge of the biology teachers. So we have absolutely to enhance that system.
Yes, indeed. So the question from the audience is, how does the primary education system connect to the healthcare system? Should we start in schools? I think the answer is yes. So, colleagues, I think we'll wrap it up there and let you go for lunch. So please thank our fantastic presenters today, Johannes on behalf of Sabrina, Jan and Maria. And I would like to thank you all for being a fantastic audience and participating really well. Thank you very much.